This excellent medical student-led podcast is for educational purposes only and not intended to be used as medical advice under any circumstance.
Welcome back, everyone. This is a special episode. We are recording from Rush today, except I brought my Northwestern colleagues over here to Rush for an exciting new thing we're going to do. Nick and Megan and Dr. Abrams are going to present a case to the Northwestern team, who will be the discussants today. So I'll let everyone introduce themselves and fill you in on what they've been up to since you heard them last.
This is Nick again. Just enjoying my fourth year at Rush, fourth year in med school, just applying to internal medicine, so excited about that. And yeah, fourth year's been great. I'm really enjoying getting to pick my own electives and getting some more time off, so really enjoyed it. But yeah, very excited for this case. Megan?
Hey everyone, Megan. I am also enjoying fourth year. Just got started with interviews not too long ago, which is exciting that I've finally reached this point. I remember starting first year and thinking how old all the fourth year med students looked. So it's very weird to now be that person. But yeah, everything's great. I'm happy to be back here for another episode and a very special one at that. So.
That's awesome. Well, it is wonderful to be here. This is Dan. You know, it's so funny being on the other side of the table. I'm here with my very good friend, former co-host, now teammate in this whole process, Lauren Smith. What's up, Lauren?
Oh, hey, Dan. How's it going?
Lauren, you know, we've been talking about the ride over, but it is so weird being on the other side of the table, but we are so excited to be doing this here.
Yeah, seriously, thank you so much for having us. We're so excited to finally meet you all in person and really get this party going.
Yeah.
So tell us more about you guys.
So, you know, the M4 life has really taken over my entire personality. I used to have dreams. Now I just sleep and no, it's great. I can't imagine it better. So, you know, I feel like with the free time, I just got back into running. So the hot chocolate 15K just happened. That was a lot of fun.
Yeah, go Dan.
So, you know, it's been nice to just kind of kick back, experience Chicago for all of its seasons, including as winter slowly falls in on us.
Yeah, same here. Interview season is starting, which is super exciting. Echoing your sentiment, Megan, it's really strange to be actually a fourth year and going through this process, but super exciting as well. I've also been spending a lot of time on Netflix, which has been great. Finished Love is Blind, would highly recommend. And lots of brunch spots to go to. So fourth year is great.
It's good to have Dr. Abrams back on my side over here. What's new with you?
Not so much. By the way, you guys talking about running. We have two very esteemed runners.
We do.
We have one very esteemed.
No, we have two esteemed runners across the way here. The only thing I want to say is that this is a fresh case. This case was from a couple of weeks ago when I was on service, and I've got to say, after 5 COVID vaccines, I finally had COVID, which was not so bad, I'll say that. But this was the last case I saw before I had to take my COVID vacation from service.
There you go.
Oh, boy.
And then
Yeah, we have
a
more
special guest. It's more of a recruitment tactic on our part, but we have part of the case with Dr. Abrams on service.
I had the pleasure of working with Dr. Abrams while he was on service, and then his check-ins throughout the week, even when he was away. So pleasure being here, and thank you for having me.
Happy to have you, Sarah. All right, so that sounds like a great time to move on to Aliquot 1. You guys ready?
Yeah, let's do it.
Okay.
Let's do it.
So Aliquot 1, we'll start with our 31-year-old female patient. She presented to the ER with a day of abdominal pain, some vomiting, some chest pain. She says her abdominal pain is intermittent, localizes to her epigastrium with some radiation to the right upper quadrant. She's also saying she has this chest pain that she describes as substernal, burning, and worse when she swallows or eats. She's maybe endorsing some chills, but she hasn't taken her temperature or measured a fever at home, no cough or urinary symptoms. And also notably, she reports about 30 pounds of unintentional weight loss over the past year. So we like to start out with our first aliquot, obviously broad, and just kind of like to get a sense of anything here that sticks out to you, or how would you approach something like this. But yeah, we have our 31-year-old female.
You know, just kind of like taking like an initial look at this. It's very interesting. We're seeing a 1-day history of this acute abdominal pain, but I'm also seeing a 30-pound weight loss over an entire year. So when I see this, I'm thinking something acute is happening, but looks like acute on chronic. So whatever is going on, clearly it looks like this has been happening for a while, but something may have triggered this to all of a sudden be an exacerbation. We're seeing this abdominal pain going up to the right upper quadrant. We're seeing this new onset chest pain. Yeah, I don't know. What are you thinking, Lauren?
Yeah, I mean, on first glance, this sounds kind of like GI related. We've got abdominal pain, of course, epigastrum radiating to the right upper quadrant, chest pain being substernal and burning, and particularly worse with swallowing and eating, makes me think more of a like esophageal process or like gastric issue potentially. And of course, you know, it's a little bit odd, I would say, for such a young patient, 31, to be having, 30 pounds of unintentional weight loss. So that makes me concerned about malignancy as well.
Yeah, I mean, especially because it's like radiating, it's like in the epigastrium radiating to the right upper quadrant. I assume at some point we're going to get some imaging of the abdomen just to see what's going on. But, I totally agree with you. What's going on with overall patient's eating history, dietary history, what's been going on, and also how's the patient's bowel movements been recently? Many changes to that. Endorses chills, so that's interesting. I assume we'll get some vital signs soon just to take a look at how she's doing. Definitely very broad, so I'm very excited to see, where we can go from here.
I'm worried about her gallbladder.
Yeah, that radiation in the right upper quadrant.
Pretty classic in chills. Also wondering why, she's had these symptoms. It sounds like this weight loss over the past year, but now really acute kind of tempo of the abdominal pain and other issues. So curious about, chronic versus acute.
Yeah, I think you guys bring up some really good points. I feel like this is a very classic patient that shows up to the emergency room, and then it all kind of comes down to, well, what do you want to work her up for? So if you guys are the EM doctors, what are you ordering?
Well, whenever I hear abdominal pain, I always am like, oh, let's take a look at let me first do a physical exam, and then let's also try to get some kind of imaging. I think classically when I hear right upper quadrant, I think more ultrasound, but when I think of other quadrants, I think of let's try to get CT, A&P. In an ideal world, I'd love to get all three. Like, let's do a physical, let's get both. But I think if I had to pick, I try to go for a CT just because it looks like it's more in the epigastrium. I'm wondering, especially with this potential malignancy like we're talking about, if we can visualize something there.
Yeah, I think I agree with you. I definitely would want to get some labs, get a CBC, MP. I would definitely want to check liver enzymes. And yeah, it's interesting thinking about ultrasound versus CT for this patient because, ultrasound sometimes actually takes longer to get than CT. And also considering this patient has this unintentional weight loss, I'm thinking maybe a T would be more helpful because we'd get more information about not just the right upper quadrant. So I'd probably also go for a CT in this patient. Also, given that she's having pain with swallowing, would probably consider getting GI on board, thinking about if we want to do a scope.
Yeah. Something else that I also was just thinking about, if this has been going on over the past year, I know we don't have a ton of past medical history, but I'd also want to ask, has a similar episode ever happened previously? And if so, has the patient been worked up just so that we can have a jumping off point? Or is this truly the first ever presentation of this abdominal pain vomiting? But yeah, kind of initial thoughts.
Yeah. Any other labs that you're thinking of other than like a CBC, CMP?
Well, I mean, especially with the epigastric, I feel like it'd be nice to get a lipase amylase one. Let's get some LFTs. Let's check alk phos Billy. Just kind of classic. Just starting off broad, and then based on what that comes in as, let's kind of go from there.
Yeah, definitely. I think you guys are totally on point with everything you want to order. This individual hadn't really been to the hospital before. There weren't any records on her, nothing on Care Everywhere. So I agree with you. It's always nice to look back and see kind of what we had before. But in this case, we did not have much. So we'll move on to the next aliquot. We have her exam here. Vitals are pretty unremarkable. She's a little tachycardic at 120, but afebrile, blood pressure 109/88. Statting well on room air. On exam, mucous membranes are a little dry, and then her belly is soft, non-distended, a little bit of tenderness in the right upper quadrant, but no rebound. Anything with that exam, vitals? I know I didn't give you too much here. So.
Yeah. I mean, with that, sounds like maybe sinus tach with heart rate of 120. Mucous membranes are dry, but this patient's been vomiting. I guess I'd want to know a little bit more about the vomiting, if it's bilious or bloody. We didn't really talk about that too much yet. So I think that would also be helpful to estimate. It sounds like this patient's just dehydrated, and that could be contributing to her tachycardia. And then the right upper quadrant tenderness is kind of consistent, but no rebound. So that's reassuring.
Yeah. And every time I get an abdominal physical exam, I feel like I'm just so used to looking at rebound tenderness to see, is there peritonitis? Do we got to bump this up, but I'm glad to see no rebound. I totally agree with you, Lauren. The tachycardia is slightly dry. This kind of seems like maybe the patient's just a little hypovolemic. When I see the mild right upper quadrant tenderness to palpation, that could be a lot of things, but I think nothing is screaming out at me saying, okay, this is something that's acute rupture, for example. I think this may be a good point to maybe get some imaging. Yeah, I'm wondering if we were able to get like a Murphy sign.
Yeah, I was going to say.
Yeah. But hey, you know what? Why not? Let's see what else comes up.
Yeah, I agree. I think still keeping it pretty broad with the exam. Can't really kind of narrow it down anywhere, but we got some labs next, which I think will help you guys a little bit.
Yeah.
On to the labs. CBC, we have a white blood cell count of 13.8.
All right.
Hemoglobin 9.8. MCV elevated at 121 and platelets 402. Her CMP showed normal sodium at 140, normal potassium of 4.4, chloride 100, bicarb notably low at 9, anion gap elevated at 31, BUN of 8, creatinine of 0.84, and a glucose of 90. Albumin 2.7, the calcium's 9.5, total bili 3, alk phos 117, and AST and ALT are 263 and 108 respectively. Her lipase was within normal limits at 14. A VBG showed a pH of 7.26 with a PCO2 of 28, a bicarb of 12, and a lactic acid of 13.1. Her urinalysis was negative, chest x-ray unremarkable, and EKG showed sinus tach. High sensitivity troponin was negative. So clearly there's lots of abnormalities here on the lab panel. I know some of them stood out to me, a lot of them, but yeah, did anything stand out more than the others? Or and Kevin, looks like you want to say something too?
Having done a few of these now, I'd like to look back and do a study on aliquots. I think aliquot 2 is kind of bland, and I think that's a sign that something juicy's coming. And I think we got something juicy here.
All right. What stands out to you?
All right, you know what? This is so interesting. I don't even know where to start. Well, let's start from the top. So white blood cell count, 13.8. That is elevated. It's interesting. We have an elevated white blood cell count, but the patient is afebrile. Now, I still am thinking, okay, could this be in the setting of some kind of a malignancy? Is there an infection? I make sure I want to have both things on the table. Patient is anemic, a macrocytic anemia. I know we don't have like a B12 or a folate, but, just other things. I'm thinking of, is there a component of malnutrition that's going on? Is that why,
Especially with her albumin of 2.7.
Right, yeah. And of course, we've got this anion gap of 31 with I think there's a lactic acid of 13.1.
That's not good. Yeah, we also have elevated liver enzymes, AST greater than ALT.
The classic 2-to-1 ratio.
2-to-1, yeah. So, I mean, there's a lot of reasons why someone could have elevated liver enzymes, but definitely puts like hepatitis, acute hepatitis on the differential.
Totally. I think, especially when I see AST, ALT with that kind of a ratio, I'm thinking, especially in the setting of alcohol use, I'm just wondering if there has been any alcohol use. I know, in the previous alcohol, there was a mention of when the patient would consume something, there'd be like a burning sensation in the chest. And I know with prolonged consumption, there can be development of certain carcinomas, and that can present some, just things that I'm thinking out loud.
Yeah, I think that's great, Dan. And especially, too, if this patient doesn't really have prior medical history, these labs are pretty remarkable for someone who was previously healthy.
Totally. Also, I could be wrong, but that T-bili of 3, that's elevated, isn't it?
Yeah.
So gallbladder, liver, right upper quadrant is definitely of interest here. I'm curious if we can get a direct versus an indirect bili, just to kind of tease that apart a little bit more.
Yeah. Lipase that's normal, right?
Yeah. Maybe pancreatitis maybe a little bit lower.
Yeah, less concerning.
We have a gas. Why don't you guys interpret the gas?
VBG instead of an ABG, so a little bit of a twist, but still, we have a pH of 7.26, which of course is still lower, so suggesting of an acidosis. We have a bicarb that is low of 12, and PCO2 of 28. So, when I'm looking at this, I'm seeing a low bicarb, low pH. I'm thinking more metabolic acidosis. PCO2 of 28, it seems like the patient is trying to compensate for respiratory, but I don't think it's enough. So I'd say metabolic acidosis with incomplete respiratory compensation.
And anion gap.
Yeah.
Metabolic acidosis too.
Yes, right, yeah. One really good thing is EKG, sinus tach, and negative tropes. So at least we can. ACS is not screaming.
Yeah.
I liked early on we had that complaint of chest pain, but I think you guys consciously but also subconsciously applied some pretest probability. It's a 31-year-old patient, no known past medical history. likelihood of her having ACS was very low. This is a nice like confirmatory rule out at this point.
And Lauren had also mentioned the type of chest pain and kind of describing things that would more localize to esophageal. So yeah, just curious. I know you guys have kind of touched on this, but if we were to like have any general guesses on whether this could be like an infectious process or not, just from what we have now, hard question to answer, but are there things that would point you in the direction of yes, this is versus no, this isn't? Or is it just kind of something that we just don't know yet? I mean, obviously we'll have more diagnostic studies, so there is no right answer, but just curious.
Yeah, I think at this point, I don't think I have enough information either way to say infectious versus not. I'm definitely concerned about like hepatitis picture for this patient, especially if there's like some autoimmune stuff, if she's in her 30s. But I think the leukocytosis and platelets are on the higher end as well. It just seems like an inflammatory state, not necessarily infectious, but maybe imaging would be something that would point us one way or the other.
I totally agree. You know, I think especially at this point, I don't think infection is what has been driving this for a year. I think at this point, perhaps it is an overlying component, but I don't have enough to completely rule it out. But I think if it is a component, there's something else as well going on that I think we're still kind of trying to figure out.
One of the things I think about a lot is signal and noise. And sometimes it's noise and noise, and sometimes it's signal and signal. So you can have some big signals and little signals and things like that. And I just was wondering if you guys, you know, as you look at this stuff, if you say, what do I really think the signal coming out of these labs is?
I mean, I would say, from my perspective, these labs are surprising given that the patient's afebrile. So, but I mean, you see a lactate of 13.1, and it's like, is this sepsis? But, you know, patient doesn't really meet SIRS criteria or anything like that, but definitely concerned about the leukocytosis, the anion-gap metabolic acidosis, and the elevated lactate. That seems to be like the signal to me.
Yeah, I was going to ask, how do you guys kind of reconcile with a lactic acid of 13.1? I remember I used to work in the ED, and one of the doctors kind of as like, you know, an oversimplification told me that like for every like one of the lactate, that basically is like the percent that the patient's going to die. So like a lactate of 2 is like a 20% chance they're going to die. So this will give her a 130% chance of dying. But she otherwise looks pretty good vitals wise. So I guess I'm just wondering what you're thinking and how you kind of like put those two pieces of information together.
Yeah, that's not good.
Yeah, I'm concerned about this patient, I would say.
Yeah.
I don't, you know, she didn't have a fever. I'm just wondering if she took something, like did she take ibuprofen or Tylenol? Like, is it masked right now, which would be helpful, but
right. I agree. I think the white blood cell count, I think at this point it is a signal. I also think that the lactic acidosis potentially suggests this patient may not be may not be euvolemic. So
yeah, and just kind of thinking about like shock and things like that. I mean, AST is the first like liver enzyme to elevate in liver injury, so it could just be not necessarily like a liver process, but just a signal of badness, if you will.
Does her blood pressure kind of argue against that?
Yeah, I mean, her blood pressure, especially with her mucous membranes being dry, it doesn't really fit.
I guess to go off signal versus noise too. I guess when I was going through this, trying to like not skip to the end. Also, another thing that stood out to me was MCV, just because like I feel like all this could happen very acutely, and like Andy, you were saying, like this could be an acute and chronic process, and I just feel like that's something that maybe like doesn't happen overnight.
Right.
And so that kind of doubles down on what you were saying is like, if this person's been complaining of weight loss for a year, we also have lab suggestion that she's not just like perfectly healthy at her baseline. There's something else here. So that stood out to me too. And so I tried to like think of things that would go in line with that. But yeah, interesting.
No, I'm trying to think of like what the problems are that she has and kind of like work through them in my brain, because I feel like there's a lot going on.
Yeah. And we always want to like link everything together.
Right.
And sometimes it's separate issues.
Right.
I know I still definitely struggle with that.
The Occam's razor.
Yeah.
Distinctive.
Yeah.
I try to be like Dr. House and just have everything comes together and just never works.
Totally.
Megan, you wanna? move on?
Yes.
All right.
So we got some imaging coming up next. Ultrasound of the abdomen showed a distended gallbladder with tumefactive sludge. No specific findings to suggest acute cholecystitis. Echogenic hepatic parenchyma, which can be seen with hepatocellular disease. Most commonly hepatic steatosis. Gallbladder sludge, but no pericholecystic fluid or visible gallstones. No common bile duct dilatation. On MRCP, moderately contracted gallbladder and motion artifact limits assessment of the gallbladder. There's minimal layering, gallbladder sludge. Otherwise unremarkable given limitations of the exam. And so at this point, general surgery was called just because there was kind of this question about whether or not this is like an acute cholecystitis. I think that we kind of learned that like it's very easy to just like work up gallbladder pathology, but I think there's actually a lot of gray area. And so yeah, general surgery, their recommendations were to admit to medicine, IV antibiotics, HIDA scan, and GI consult. So yeah, given all of this, what are you thinking? Is this enough to kind of like rule out gallbladder pathology? What do you think you'd want to give antibiotics wise? Do you think they're correct in prescribing antibiotics? What are your guys' thought process at this point?
Are you satisfied with this?
Answer any questions for you or
does
just
this frustrate you?
Admit to medicine. What are you thinking, Dan?
So this ultrasound is showing a distended gallbladder with tumefactive sludge. So I guess I'm thinking, why aren't we seeing appropriate contraction of the gallbladder to like facilitate movement of this sludge? But I'm also seeing no common bile duct dilation. There's no such sign of stones or any kind of cholelithiasis that may cause like fluid around the gallbladder. I know something that kind of fits is like acalculous cholecystitis, but I'm not sure how to interpret, especially these MRCP findings that show minimal layering. Like, how does that impact?
Yeah. I mean, sludge just by itself doesn't seem that, profound. There's no common bile duct dilation, so that there's not a clear mass or something causing that, which is, doesn't necessarily rule out malignancy,
Right.
but would be, is good for this patient. The echogenic hepatic parenchyma, I think, is kind of non-specific and not super helpful. So I don't make too much of that at the moment. And yeah, of course, it's motion artifact limits assessment, so that makes it hard.
Clinical correlation.
Yeah.
It's a real world example right there.
Yes. But yeah, minimal layering. But I don't really know the significance of that, like the distended gallbladder.
Yeah.
Yeah.
I think a lot of attention has been focused on the gallbladder and the liver. I think we're searching for something at this point that's just not there.
But it's possible. It's
Yeah.
possible. Now that you mention it, yeah.
Good point.
I mean, so just thinking back to this patient's initial presentation too, there's a lot of other stuff going on, right? This patient is vomiting, they're having pain with swallowing. That doesn't totally fit with a gallbladder pathology. So, maybe we're zooming in too much into the gallbladder, and I think GI consult and maybe scope would be helpful.
Yeah, I think with this case, it's easy to zoom in on the gallbladder because, the patient was subjectively complaining of right upper quadrant pain. We had labs that may be localized there. So I guess first step, I'm not surprised that these tests were ordered, but it was a little bit unsatisfying here. Excuse me, what it's saying. Kind of think you guys, what you're saying is reflective of that.
Yeah, I think this is a great example of just how challenging it can be to work up abdominal pain and how few times you actually get answers for what's causing it. Even when you're in the hospital and you're getting all the tests, we're like, oh, we'll get an MRCP, that'll give us our answer. And then it's still exam is limited. But yeah, something I did learn is that sludge actually can cause pain. So you can get little stones within the sludge that make it really hard to see. So you can get some colicky type abdominal pain. So it'd be hard to kind of attribute everything that's going on to this gallbladder sludge, but sometimes it's always nice to think maybe you have an answer to at least part of it. So it could explain her pain. What do you think about the liver? I feel like for a patient that, hasn't been in before, doesn't really go to doctors often. Sometimes you have to use the lab and imaging findings to kind of backtrack and figure out what their medical history is. So what do you think about the hepatic steatosis?
Yeah, I'm definitely concerned about her liver. I think that the imaging finding in and of itself is not necessarily specific, but I think it would warrant certainly more of a social history and figure out, does this patient drink alcohol? What's their history? Is there any thinking about autoimmune hepatitis, is there any history of autoimmune disease in the family? Yeah.
I'm also wondering maybe if on physical exam, we take a look at the size of the liver. Is there any compression of surrounding structures that may be contributing to irritation? This hepatic steatosis, this looks like a chronic issue. So, also going off what you said, Lauren, what has been the patient's kind of base, like how has the patient been prior to the year? What was the patient's diet, like intake? How has the patient's normal, like activities of daily living been like? Because I imagine even this, it probably started more than a few months ago. It's probably a long-term process.
I will give you guys one additional piece of history that you guys should have given them, and that is she was in no way cachectic. Okay, so she was. I don't remember her weight. I think she weighed.
I'm just gonna ask.
Okay.
I think she weighed
Her
about
BMI
one.
was 26, I remember.
Yeah,
26, okay.
26. So she was not
She's
cachectic.
well. Okay.
Okay.
Yeah.
You said this 26.
Sounds.
I think I remember reading that.
If Megan remembers it that way, then that's
Okay. Perfect.
But also,
Yeah.
also not super high to suggest a cause of hepatic steatosis that would be in line with someone who is like morbidly obese. And yeah, hepatic steatosis also, like you guys are saying, definitely not something that we're like acutely worried about causing a presentation, but not something to be ignored. Like this can progress to cirrhosis. We have really good treatments now for weight, and we know that weight loss is associated with decreasing evidence of hepatic steatosis. So that's also something to keep in mind.
Yeah.
And yes, like you said, the chronicity of hepatic steatosis.
I guess, yeah, that's the biggest thing right now that I'm thinking about is what is acute and what is chronic, because this patient, I mean, I don't think the lactic acidosis is going to be a chronic thing, but certainly, you know, the macrocytic anemia may be chronic. So it's just, yeah, it's hard to know without, you know, any records too.
Yeah. Any further tests that you guys want to get? And what do you
So
think
what
about
the
And you know me, I'd love to get a CT if we can, just to take a look at the rest of the abdomen.
And what do you think? It sounds like they're kind of treating her for a sepsis picture with these IV antibiotics. How do you guys feel about that?
I don't really feel too strongly one way or the other. I mean, there is an elevated white blood cell count. I cannot disagree with that. I personally don't really feel bad about starting it, especially if we start kind of broad. Obviously, I'm not throwing in like a very high-powered, not throwing in meropenem. Right at the top.
Yeah.
But I think it's okay to start broad and kind of see where things go.
Yeah, I mean, I guess my thought is, I know this patient's not febrile, but with a lactic acid of 13 and a white count, I think it makes sense to start something initially and then kind of maybe peel back as we get more information.
Also, I mean, I don't know if this was touched on, but before we start the IV antibiotics, maybe we can also get like cultures, like blood cultures, urine culture, just so we have that before we, you know.
Yes, very good point. ID would be very happy with you for drawing cultures before giving antibiotics. Okay, good. So we have a couple more tests.
All right. So we have the HIDA scan, which was unfortunately inconclusive. There was non-visualization of the gallbladder during initial 60 minutes of imaging, which is considered abnormal. Additional imaging needed for further evaluation, but the patient refused. The iron itself was within normal limits, or just a little elevated, 193 with upper limit of normal at 170. Ferritin is markedly elevated at 1,196. Total iron binding capacity and percent saturation unable to calculate due to result outside of reportable range. The folate was undetectable, and the B12 was 316, which is slightly on the lower range of normal. Haptoglobin 53, which was normal. LDH elevated at 508. Peripheral smear without schistocytes, normal morphology. Reticulocyte count 0.69%. There was a central hypothyroidism with TSH of 0.223 and a T4 of less than 0.6. And then hepatitis panel and HIV are negative. Some new findings here. Yeah, so what do you guys think?
You know, you guys are giving us some very, very interesting data here. I'll just start somewhere and we can just
go for
bounce
it.
off ideas. So the first thing that kind of sticks out to me is this patient has this anemia, this long-term anemia. But normally I would expect the reticulocyte count to be a bit higher if a patient did have anemia. There's a body trying to increase those numbers. That's a normal reticulocyte count, which I feel like I would not normally expect. So I'm a little concerned why it's not elevated. Also, it looks like the patient's thyroid levels are low, but the TSH is also low, which suggests, again, the central hypothyroidism. So I'm wondering what if there's a component to this. Also, of course, folate undetectable. Maybe that's also contributing to the macrocytic anemia.
I'm also thinking, like, the HIDA scan. Why? I'm trying to think of why you would not see the gallbladder. I don't know if there's, if that would happen from hepatomegaly or...
Yeah. So apparently it can be A, because there's like some sort of gallbladder pathology, or the gallbladder is just contracted, and so it kind of takes
Okay.
longer for.
Which makes sense because they said it was
So
contracted.
no one really knows exactly what's going on.
Think about like how like a HIDA scan works. So it's like functional. So you'll inject like a radionucleotide that will go into the liver, and it will basically bind to all the bile that's produced. This may be a rough explanation, but then we can track that bile in the biliary system. And so normally it's supposed to go eventually, down the ducts. Some of it goes into the gallbladder. If none of it goes into the gallbladder, sometimes that can tell us that there's an obstruction of like the cystic duct leading out of the gallbladder. But
Nick just finished GI. Isn't that great?
So we've got a big question mark then on the gallbladder.
A further example of how sometimes more tests still can't get the answer.
Yeah.
All right,
I
what do you-
guess,
what do you think about all these irons?
yeah. So I was going to say, ferritin is also an acute phase reactant, so that I think that's probably why it's elevated. So I don't know. Do you have any other thoughts on that? Ken?
So the TAB, I've never seen a TABC annual because it's outside of the reportable range.
Yeah.
So I don't know. What are your thoughts? What are you leaning towards?
I know. I'm trying to remember how they're calculated. Like if that would be because of the ferritin, or if it would be separate.
I think my first thought is if the ferritin is this high, I think there's a point of inflammation that's happening that's potentially leading to this very, very elevated ferritin. Percent saturation, it's outside of the reported range. I'm thinking it's probably low.
Yeah, because they're opposite,
Low,
right?
right,
Ferritin
right.
and
Yeah. So is this like anemia of chronic disease? Is this? I'm not sure.
or maybe acute on chronic.
Right.
With this acute phase.
Yeah. We may not be able to pinpoint a diagnosis out of this, but
Yeah.
clearly something chronic is going on.
Yeah. Haptoglobin. Yeah, interesting. Folate is undetectable. I've never seen an undetectable folate before, but B12 is normal. Which is interesting.
Yeah.
LDH, I guess with LDH being elevated, I don't know, I'm more concerned about malignancy
Right. Yeah.
in this patient. Yeah. Especially like hepatitis and HIV is negative. I don't know.
Right. I think especially like getting into like a social history, because I know one of the most common forms of folate is especially through like leafy greens and like I just want to make sure I'm getting a full picture on the like, dietary history on like what else could be kind of contributing to an undetectable folate level.
that is exactly what next question I was going to have is like, what do you want to know from the patient? I mean, like things that would cause a low folate level. We usually like to think of the diet. So yeah, that's something that definitely we would want to know more from the patient. And yeah, I guess that generally, like you guys are saying, this kind of screams more chronic process. Again, it's kind of been like a theme that we've been going on. So
Yeah, just a fun fact about the iron studies. I was also curious about how exactly these were calculated. So yeah, basically the TIBC and the UIBC, and you can now apparently measure directly like the transferrin level. So they're all looking at the amount of iron. So basically it like takes your blood and then adds more iron to it and sees how much more can be bound. So if it's high, that means that there's like iron deficiency because you're adding more iron and your body can like take up a lot more iron. Versus if it's low, that means that there's already a lot of iron in there and so it can't take more. So yeah, in this case, I think we were thinking that the percent saturation was high just based on the iron being high and the ferritin being high and then the TIBC being very low. I'm not sure if you had anything to add to that, Dr. Abrams.
I think you guys are doing great.
Okay, so yeah, I feel like this might be a helpful time to kind of go back and just like maybe talk about the problem list because there's a lot going on and maybe related, maybe unrelated. It's hard to say for sure. So what do you guys think so far? And what progress, I guess, can we make on the problems that we have?
Yeah. Let's see.
Well, I think kind of the initial presenting problem was this new onset abdominal pain that started one day ago,
Yes.
along with the vomiting and some new onset chest pain that with some soreness and pain, especially on swallowing. And of course, there's this long-standing, year-long 30-pound weight loss that's been going on. We're trying to figure out what that might be contributing towards. When we did some lab studies, we were seeing a pretty significant metabolic acidosis with an elevated anion gap of, I think it was 31. On imaging, we're seeing signs of a moderately distended gallbladder, but kind of unclear what really is happening in the right upper quadrant. We're seeing some hepatic steatosis. And, even here as well, we're seeing an elevated white blood cell count and labs that are suggestive of a chronic process with an unclear uniting diagnosis right now. Lauren, what are you thinking?
Yeah, I think, I've got abdominal pain, macrocytic anemia, this
right.
lactic acidosis, hepatic steatosis, question mark on the gallbladder,
Right.
hypothyroidism, which I'm like trying to think about how these,
Right.
or maybe it doesn't. Maybe she just has thyroid disease that's undiagnosed. But again, this patient is very young, in their 30s. This is also like prime time for autoimmune disease
Right.
to come up. But yeah, this LDH and ferritin.
Right.
Yeah, some weird stuff going on.
Yes.
All right. So yeah, for the first problem, we have like this abdominal pain, nausea, and vomiting. You guys don't do anything more about it? You think it's been fully worked up? We also got a CT, which didn't show anything, just redemonstrated this hepatic steatosis. So we do have that piece of information for you. I know you were waiting for it.
Oh.
I still kind of want to scope her.
Upper, lower, both.
Upper, unless she's having, bright red blood per rectum, which isn't anything that we've gotten so far in the history.
She actually is. We didn't put that in yet. But
Okay.
So yeah, this was kind of a little side thing that was going on. It's been kind of like a chronic intermittent problem, just like a little bit of blood every once in a while when she wipes.
Okay.
Per rectum.
Per rectum.
Well, I mean, she has a pretty significant anemia for a 31-year-old woman. So I would probably do upper and lower because she had pain with swallowing. I definitely want to ask more about that if she has like globus sensation, if she feels like food is getting stuck in her throat, how long exactly that's been going on for. I think I'm not clear on the time course of that particular issue. But certainly if she is also having bright red blood per rectum, I would want to do upper and lower endoscopy.
Yeah. And like going off of all of that, especially if the patient is continuing to have nausea, I just want to make sure that the patient's current nausea symptoms, like we're also like addressing that, right? Giving her appropriate anti-nausea meds, making sure like she feels comfortable sitting upright when she's eating to kind of minimize some of that burning sensation. So if she lies down, that's probably exacerbated. Making sure that, when she's going to the bathroom, if she needs help, especially if it's painful, if there's blood, that, we are able to like take a look at it or make sure that, things are going okay. But I definitely agree with everything Lauren here suggested as well for further workup.
All right, I agree with you guys. Let's see, next problem. So she has these kind of LFT derangements, the hyperbilly, the AST and ALT. We got a hepatitis panel that was negative. That included like EBV, CMV, HIV. Anything else you guys want to do to work that up? You want to chalk it up to something else? What do you think?
I'm thinking back. I know at Northwestern we have a whole panel that you can put in Epic. And
Yes,
says
like I want the hepatitis
elevated-
panel.
We have one here. That one.
I want that.
It was that.
I think they check for like what is it? Alpha-1 antitrypsin, which, I mean, we're not really getting any history of lung disease, but,
Yeah.
that just could not have progressed yet. So would be something to check. And I think there's a bunch of other antibodies for like autoimmune hepatitis that I would want to check.
Anti-smooth antibody for autoimmune
Nice.
hepatitis.
Nice.
That sounds.
Yeah, so I would definitely want to check those. Also, I don't know if I'm thinking also about like a drug-induced liver injury. Check. I mean, it doesn't necessarily sound like acetaminophen toxicity, but we could always check a level. So I would want to know if what meds she's taking. We haven't really talked about her medication.
Yeah, a lot of meds that can cause it.
I guess steroids would be the only other question of like, would we?
Elevated white blood cell count.
But she also, is this infection? Is this not? So I would probably not at the moment, but
Yeah.
Always a good thought. Go ahead.
So, I mean, I don't think this is very pertinent, but I'm wondering if we can get like a cortisol ACTH as well, if that might be helpful. Just, it's something that I always think about when we have this kind of a picture as well, just to see what is the ACTH looking like.
Yeah,
Is there
that's a
the
good
point of Cushing?
I think like the image negative abdominal pain, you always have to
Right.
think about like adrenal insufficiency as a cause for it. That's a really good thought. Okay, this macrocytic anemia. Do you guys feel like you got an answer on that?
I'd love to know her social history.
At this point, I don't have an answer for anything, okay? Let me just start.
Yeah. I guess I'm also just thinking generally about like malabsorptive process for her, which could also, contribute. So I want to know her alcohol use history, just general diet history, like Daniel, you mentioned earlier.
Yeah, totally. It's like with this undetectable folate, is she not taking it in? Is she not absorbing it? Yeah, those are always kind of the big questions to ask. All right, I think we can move on to the next one. Anything you want to add, Dr. Abrams?
No, I'm interested in what the next aliquot is.
All right. So evaluated by GI, recommended EGD, colonoscopy, the tissue transglutaminase / IgA, and then a hemochromatosis panel, because kind of based on those iron labs is more suggestive, more of like an iron overload picture. So we've got an EGD and colonoscopy to showed mild inflammatory changes, but no explanation for the patient's pain. A normal tissue transglutaminase with a normal IgA level, so you always want to check that to make sure they're not IgA deficient. And then also a hemochromatosis panel, which was negative.
Interesting.
Is it another dead end?
No. Every closed door is a.
There you go. What is this? I haven't heard this.
Yeah, I just made it up.
I like it. I like
Sounded
it.
very loud.
Inspirational quote, but
Very optimistic.
it's a bad.
Yeah.
Dan likes his doors open.
Yeah, that's what it is. That's what it is. Anyway, it's interesting. We were just talking about malabsorptive, and we were looking at a TTG, IgA, which I assume they're looking into like celiac disease.
Yes, exactly.
And if those are normal, it's suggesting that perhaps this patient does not have the celiac. The colonoscopy and EGD, great one. Like they really listened to it, so totally. So,
It was all because you said that. So we're going to do it. And Lauren's like, I want it.
mild inflammatory changes, but no explanation for the patient's pain. So yeah, I don't really know what to take from that. I'm not really seeing any signals.
There's no comment either on like active bleeding or anything, so maybe it's like hemorrhoids or something and not actually
Totally.
internal.
Very much the anal fissure too, like something. Yeah.
Yeah, I think I remember reading somewhere that most causes of like rectal bleeding in young people are like pretty benign, but obviously something important to get worked up to make sure that it isn't something scarier.
Yeah.
Well, before we go on to the next aliquot, I guess I was wondering just about the lactic acidosis. So let's say like, it's so sweet, right? Yeah, it's like the thing that's screaming is like as an acute process, but let's say like we're treating her for an infection here, and like it's not really responding on antibiotics. So like we're not getting better with like our antimicrobials, and of course we like to think about infection, but how does that change how we think about lactic acidosis? And I know that's can be kind of tricky, so we can help lead you through it because we talked about it before, but like building up lots of lactate, but not necessarily maybe because of an infection. Does that drive thinking, and or can you tie that into anything we've seen as well?
I think for me, I think it kind of further maybe lends itself to, we were talking about malignancy a little bit earlier on in our discussion. Like when I think of lactic acidosis, I think of a mismatch between oxygen supply and tissue demand. And when I think of malignancy, I'm thinking of there are more cells that are being developed, and so there's a greater demand, but supply is the same or probably decreasing. Potentially that's contributing to this lactic acidosis picture. And like you're mentioning, if antimicrobials aren't really doing anything, maybe something else entirely is going on that's driving these changes.
Yeah, we've talked we've talked in the past about we have like two general types we like to think about. Type A, where we have like hypoperfusion, so like the tissues, the cells are not getting what they need. So we'll think of like septic shock or cardiogenic shock. Then type B would be like we don't have any evidence of hypoperfusion. There's some, but the cells are just still not doing like their job, and so.
What's this question mark?
I didn't say it.
We're talking about the Warburg phenomenon.
I didn't say it. You said it.
Yeah.
But yeah, so that's just, I guess, something to think about. Something you've been leading to. Is there anything in this case that would explain maybe a problem at the cellular level as to like why lactic acid is building up, or any like?
You haven't heard that word since
I know, like, yeah, I don't know. Are there any labs or like?
The
Hard question. Hard. Yeah.
The LDH was elevated, right? So I think that also lends, like, perhaps there is increasing cell turnover. I don't know if that's where we're going with it, cellular. I don't know, Lauren, is there any other lab that you can think of that may have?
I don't know. I mean, I'm thinking like tumor lysis syndrome is a thing that exists.
Yeah,
We didn't have a really elevated potassium. We could check a uric acid, but I don't know that that's what's going on here, but it just.
So over the next couple days, she's admitted for a couple days. Her abdominal pain starts to get better. She's eating, she's drinking, she's doing okay. She got antibiotics, she got fluids. All around, she's doing a little bit better, but she just has this persistent lactic acidosis. So it's real life. What are you guys doing? The answer could be Google. Reasonable answer.
That's a great answer.
But what are you thinking?
What are her other labs looking like at that point? Like, are they
Her
still?
LFTs are downtrending.
Okay.
Her Billy normalized.
I'll give you two other labs just so you know that these guys left out early. And one was her CRP was less than 5, and a SED rate was, I think, 5.
Yeah, they were both.
Very low.
Maybe less inflammatory.
Inflammatory. And the CT just showed nothing.
Well, we don't have a CT,
don't
right?
have a
She didn't want more imaging.
No, she got the CT.
Oh, she
needed
did.
like some
Okay.
special imaging for the high scan.
Oh, got
she
it.
didn't want.
Okay.
But the CT was okay.
What are you Googling?
Um,
Do that every yeah.
I think, I'm thinking persistent lactic acidosis in the absence of other symptoms.
Nice.
Yeah.
Help.
It's my morning ritual. I type help into my computer.
So I'm trying to think of like what our problem list would be now at this point for this patient. So persistent lactic acidosis, but now she's not really having abdominal pain. Colonoscopy and EGD were not very helpful. But I guess, I'm thinking more of an autoimmune potentially, but I don't know. I would be searching differential for type B lactic acidosis.
All right, so we got one more aliquot for you, and I feel like when you hit dead ends, you always just want to go back and talk to the patient, talk to the family, see if there's anything that you're missing. So we got this last aliquot. When discussing with the patient's mother, she knows the patient's been drinking a significant amount of alcohol for the past 6 to 12 months, and they got a thiamine, which was very low at 32.3, lower limit of normal being 66.5.
Yeah, so when I see an alcohol use for 6 to 12 months, this kind of suggests a lot of the other things we're thinking of, especially when we saw the AST, the ALT, B1 about 32.3. I would want to, just thinking in terms of like immediate next steps, anytime I see a low thiamine level, I'm concerned about potential development of like Wernicke's or eventually, of course, Korsakoff syndrome. So making sure the patient has glucose, thiamine. I think that's all part of the banana bag.
Yeah.
So just the classic, just make sure that the patient is getting those things. Because I think the lactic acidosis could be contributing because if there's no glucose, you're just defaulting to anaerobic metabolism and you're just constantly generating lactic acid. So like, no matter what, we can keep giving this patient fluids, but if there's no thiamine, I think we're just not going to get anywhere with the glucose. So we got to get the thiamine back up.
Yeah.
What does thiamine do?
Kevin's being mean today.
Come on.
That would be my Google question in the morning. Like,
Yeah.
Yeah.
What's thiamine?
I mean,
what is thiamine again? Question mark?
I'm just remembering the video about like berry, wet and dry, and I'm trying to remember what the difference between the two is.
I think one of the cool things is to think about just what you're saying there, and that is, think of the things we know that are associated with thiamine deficiency. So you guys have hit on 2 things already, right? But you've already mentioned 2 things that come quickly to your mind. What are they? Berry, right?
Yeah. And alcohol.
And Wernicke's, right?
Doesn't look like she's having altered mental status or anything to suggest.
Any confusion.
Yeah, or like nystagmus. Yeah. So I'm less concerned about that. Certainly concerned about the alcohol use, but I don't think that's necessarily. Yeah, I don't think it's Wernicke's.
So what does this explain for you in terms of like the problem list? Like LFTs, anemia, abdominal pain. What do you feel like you can tie together? What do you feel like you still aren't sure about? What do you think was signal? What do you think was noise?
I think the low B1 is a signal. I'm gonna lock in on that. I think a few at least of the patient's symptoms may be tied to the low thiamine level, and I am expecting that upon repletion of the thiamine and glucose, we should see improvement, at least some improvement, particularly in the lactic acidosis. And I'm hoping that the abdominal pain might improve a little bit, just because there might be like improved tissue oxygenation and improved like glucose utilization.
So what I'm hearing from you, Dan, is it sounds like you want a TX to DX.
Yes. That's a great that's book for the books. TX to DX. That's a good one.
Yeah. I mean, I think a lot of what we have on our problem list for this patient can be explained with this history of alcohol use and this low thiamine. I mean, the abdominal pain, macrocytic anemia, this hepatic steatosis that we saw in imaging. I guess something else I would be concerned about in this patient is like we should probably be getting CWA scores. Like I would be concerned about withdrawal for this patient.
Megan, you may know the answers. I've got one more lab that you didn't tell them either, and that was her INR.
Yes. There was one INR that was elevated when she
Okay.
first came in. It was about 1.37, I think. It did normalize while she was admitted as well.
Okay.
So maybe that's just at least earlier on the hepatic function may have been slightly impaired, but perhaps perhaps things have improved. Okay. I also don't know if a low thiamine level would be the sole contributor to I think it was a 30 pound weight loss.
Yeah. So I guess it's what's cause, what's effect, right?
Right.
Right. Yeah.
I want to talk to this patient and see, what's been going on the past 6 to 12 months.
Yeah.
Was there any trigger that,
Right.
started this increase in alcohol use? Is that related to the weight loss? It's unintentional, but what has changed in the past year or so?
Definitely. The person, the social history, I think just talking to, like you said, talking to the patient will probably help us a ton, especially in this case. Yes.
Anything else I forgot, Dr. Abrams?
Yeah, I think you hit all the points now.
He's salty over here.
No, I apologize.
So if we were to piece together a diagnosis or like a unifying cause, how would we articulate this here? Kind of a tough one for this one, but
I'm looking at my notes here and trying to cross things off my list.
You guys have already said it too.
Yeah.
You guys kind of gone over
you
it.
pretty much said it. Yeah.
Yeah.
Everything. So yeah, the way that they kind of tied this all together was that this is a B vitamin deficiency in the setting of excessive alcohol intake, complicated by a type B lactic acidosis and macrocytic anemia. So the patient was treated with IV thiamine with resolution in her lactic acidosis, also given folate and closed outpatient follow-up to monitor for improvement in her anemia.
Nice.
Wow.
So
This is unique, at least for me. This is like I haven't actually seen this. Like,
Yeah, I can't say
manifest.
it.
Like read about it, but I've never like seen this manifest clinically. Sarah, you got to see it before I did. Wow. Yeah, interesting one to learn about for sure.
yeah,
This
there's. Sorry, go ahead.
I was just going to say it's just interesting to see how all the problems come together because there were so many lab abnormalities. So yeah, definitely good reminder of other reasons to have a lactic acidosis for me.
Yes, that is a big one. So yeah, I think not all lactic acidosis means infection. So definitely something to consider, but also important to not just treat every patient that comes with a lactate of 13 for sepsis. And yeah, I feel like we see a lot of patients with cirrhosis, which is kind of like the end stage of, they've been drinking for too long and now they're kind of at this unfortunate irreversible place. But I feel like this is a really good example of someone who's not there yet. And so we have like a really good opportunity to intervene. And sometimes they might not be like forthcoming with, all this information. And so being able to like look at the labs and kind of work backwards. Like you said too, I think that was a really good point about like monitoring for withdrawal and a lot of the other things that if they're not telling you about it, it should always be something that's kind of in the back of your mind. So yeah, I thought this was an awesome case. Dr. Abrams was super excited about it.
So I still say this is the real issue is her Krebs cycle was broken. I don't know. Are you guys going to tell us about that?
Yeah, we have some teaching points.
So this is.
Look at this.
I'm going to tell you, and this is because I'm not nearly as smart as you guys. Okay.
No, that's not
I am
true.
just going to tell you that right now. And so, literally, I saw this patient. Like I told you, she came in. I don't know if you were there, Sarah. I was with Monique at the time, and when I saw her, which is maybe about 10 hours or 12 hours after she came to the ER, she looked great, and so I was sure she wasn't septic, and then the question really is okay, what's the differential diagnosis of lactic acidosis? So when we talk about, that's why I talk about signal here. To me, there was the strong signal pieces were the lactic acidosis and the macrocytosis, and because they connected. To me, those were the two pieces that connected the most, because the reality is there's really only one or two things that can cause macrocytosis, right? Yeah. And so that was easy. And once I knew her B12 level was normal, then I knew her folate level had to be abnormal. And then I knew she had one deficiency. And then the question was, why doesn't she just have two deficiencies? And because you guys will tell us in a minute, that is a cause of lactic acidosis. It's when we miss. I don't know if we miss it, we don't think about it. I know I was talking to one of the critical care people. They say, "Oh yeah, we always look for this." And then they do or not, I don't know.
I feel like we've known about this forever.
Yeah, that they say they've known about it forever, but I've never seen it talked about. So that was always sort of this. That was the signal to me. I will say this also. So literally, I am feeling worse and worse as the day goes on. And before I go home that day, I'm like, okay. I called up. And I very rarely order things myself as an attending. But that's because our senior was gone that day. And I put the orders in myself to draw thiamine level And then I called up the intern. I said, can't do this until she gets this lab. But you're going to give her a dose of IV thiamine afterwards. And then we waited 5 days for the result to come back.
You want to take us through some teaching points, Nick?
Yeah, let's do it. So we'll talk about thiamine deficiency. So thiamine, we were asking earlier, it's a vitamin, B1. It's water soluble. We find it in a lot of foods that we eat: yeast, legumes, pork, brown rice, whole grains, whole bunch of things. And so this is a deficiency that we see mostly in populations without whole grains or individuals who consume a lot of alcohol, which is the case in our patient. And so thiamine is required for pyruvate to enter the TCA cycle. And so without it, we just rely on anaerobic respiration, build up lactic acid, which is what happened in this case. And so we talked about some of the syndromes, so beriberi and Wernicke-Korsakoff. So beriberi can be classified as either dry or wet. When we think of it as dry, we think of the peripheral neuropathy, and wet is usually cardiac involvement with cardiomyopathy and high output heart failure because the tissues are so demanding. And then with Wernicke-Korsakoff, so this is the devastating neurologic complication of thiamine deficiency. So Wernicke's would be acute encephalopathy, and Korsakoff is the chronic condition that is a consequence of untreated Wernicke's. And this is what we classically think of short-term memory, confabulation with otherwise intact cognition, which is a little bit of a bizarre affect to have. So that's a little bit about thiamine. Megan can tell us a little bit about this iron overload that we see.
So yeah,
with
this is something
alcohol.
I was actually really interested in because I saw the labs. I was like, oh, she has hemochromatosis. This is so cool. But she did not. And I feel like the only thing I've ever learned as a reason for iron overload is hemochromatosis. So I actually did a little searching, and turns out patients who drink a lot of alcohol can actually commonly present with iron overload like she did. And so it's not completely understood why. I think it has something to do with like hepcidin regulation, which is then driven by alcohol. But it is kind of important because first off, they have hemochromatosis and they're drinking. They can just like destroy their liver way faster. But you just kind of get, with increased hepatic iron content, you basically can get like more of these like free radicals and pro-inflammatory cytokines. And so it can kind of cause the liver damage to happen sooner. So I thought that was an interesting point. And also with like the central hypothyroidism, I know GI was actually like worried that this was a hemochromatosis because you can get like infiltration in the pituitary. So we have no explanation for the central hypothyroidism. We were thinking probably just like due to malnutrition, which we have seen like some case reports and stuff of that. And I think just pathophysiologically that makes sense. But yeah, that was kind of something new that I learned with this case, which I thought was cool.
So I got two other things. So first of all, just as add-ons to this, because the case was so interesting to me, so I'd say that. But I've added lots of vitamin. I added every vitamin level we could get here back, and most, it's been 2 weeks now, and but her vitamin A level came back
Yeah, that was
today.
low. Yeah.
That just came back low, and I'm waiting for her vitamin C level.
Vitamin E was normal.
Vitamin E was normal.
C is pending.
Yeah, it was low normal, and her vitamin C level is pending. And I'm just assuming that the elevated INR could have been vitamin K deficiency,
Yeah.
right? So you could say it's liver disease, but she really doesn't have, her liver function's all totally normalized after.
Yeah.
Like you say, I think all of a sudden she could do, I just thought she was metabolically broken.
Yeah. That's a good way
But
to put
I
it.
got one little piece of stuff here because I do go back, and to me it's, and I'm way farther out of medical school than you guys are, and I still have nightmares about the Krebs cycle. And so to me, this is the Krebs cycle coming to life in medicine. What other places does it really come to life? So here we go. So here we go. What would be the perfect revenge for a scientist whose paper is turned away from Nature? So answering this is, how about a Nobel Prize? And such was the case for Hans Krebs, the biochemist who received the Nobel Prize in 1953 for discovering the citric acid cycle, which is what we call this Krebs cycle. So Krebs was a German-born, he was Jewish, he was trained in medicine and chemistry, and he left. He started out in Germany, and he left as the Nazis came to power. He went to England, actually, where he joined the faculty at the University of Sheffield in 1935, and that's where he achieved his groundbreaking discovery. So in 1937, Krebs and one of his colleagues, and I think there's a couple of people who got the Nobel Prize, so they minced up some pigeon breast, and they suspended it in a solution, and they watched its metabolic rate decline over time. And then they added citric acid to it, and what they found is that they could keep the tissue alive for a lot longer. Okay, so they did more experiments, and they found this sort of cyclical nature. And so that's where the Krebs cycle comes and all of this ATP stuff. So anyhow, so Krebs then goes and he submits his findings to Nature, only to quickly receive a note from the editor saying that the journal had a backlog of stuff and that they wouldn't publish his paper. So later in his memoirs, he writes, "This is the first time in my career after having published more than 50 papers that I experienced a rejection." So he resubmitted his findings to some relatively obscure journal that published it right away. And so in 1988, 7 years after Krebs dies, an anonymous editor published a letter in Nature calling the rejection the journal's most egregious error.
Wow. I
So
have not heard that before.
So that's a cool story about Krebs. Wow. I think this is a cool case about Krebs.
I agree.
Yeah.
Makes me just want to grab a dry erase marker and start drawing it out.
Let's not get too far.
I don't know about that one. All right. Any reflections on the case? You guys are wonderful.
Thank you. It's so interesting. I think, even as us as discussants kind of walking through the way the case kind of evolves and you start at point A when you try to keep things broad, and as we're going and we're getting these gallbladder results, and we're thinking, and what does the sludge mean? What are we doing? But it's just so great to see everything kind of come together with this one unifying picture. So, yeah.
Yeah. Not so much related to the case, but this is Daniel's and my first time being on the other side of the mic, and it's been awesome. So glad we get to work together on this case, and just really glad to be here and go through this case with you all.
Yeah. Thank you so much.
Super fun.
Thank you guys. You guys were fabulous.
You did an amazing job. All right. And thanks to all of our listeners. We'll see you guys next time.
Yeah.
And stay tuned for when we flip the script again and have Megan and Nick in the hot seat, with Lauren and Dan presenting a case at Northwestern.
I'm going to be sick for that.
Bring it on.
Thanks again for listening. Person, time, and place. We'll see you next time.